Welcome back. This is Dr. Rockhold again, continuing our discussion of drugs of abuse. The focus for this session will be on marijuana and the cannabinoids. As we mentioned earlier, you're going to be entering practice at a time of significant change in how this state and this country interact with the substances derived from cannabis species. That genus, cannabis, contains at least 3 species: sativa, indica, and ruderalis. There's some discussion about these all being subspecies of cannabis sativa, but that is currently taxonomically unresolved. Regardless, all 3 of these species have a significant content of psychoactive substances, primarily, but by no means exclusively, including delta-9 tetrahydrocannabinol, or THC. Beyond that, cannabis contains hundreds of identifiable compounds and many dozen members of a unique family of terpenophenolic compounds called cannabinoids. Of these, the most well-recognized and the most psychoactive is, of course, delta-9 THC. Another significant member is cannabidiol, or CBD, which is not psychoactive and which is now rather generally available. You will also need to be aware of 3 agents that are available as prescription agents. These are dronabinol, marketed as Marinol, nabilone, marketed as Sesamet, and cannabidiol oral solution, or Epidiolex. Dronabinol is a synthetic delta-9 THC, while nabilone is a synthetic cannabinoid, which is similar to but chemically distinct from delta-9 THC. If you are interested, I think one of the best summaries of both the positive and negative effects on health of the cannabinoids was published by the National Academy of Sciences in 2017. If you want to do any further reading, I've provided the link to you, as you can see on this slide. While the focus of this session will be on cannabinoid pharmacology, I think it is instructive to frame some aspects in the context of other abused drugs. The graphic shown on this slide ranks commonly abused drugs according to their therapeutic ratio, which is calculated as the effective dose divided by the lethal dose. It also shows how each agent is tagged according to the controlled drug schedule of the Drug Enforcement Agency. You'll note at the very top of this graph is cannabis, presumably in its herbal form, and that agent is remarkable for the extremely low level of risk for lethality. In fact, it's hard to identify a scientific report of death caused directly by cannabis intoxication. That excludes, of course, motor vehicle accidents and drug-associated violence in which cannabis was involved. You may note also that despite this lack of lethality, cannabis is a DEA Schedule I agent, which means it is in the same category as heroin, which you'll notice at the very bottom of this graphic. At this juncture, I think it's important to recognize that the DEA control schedule is based on whether a drug has a recognized therapeutic use and whether the drug has a high liability for abuse. The controlled drug schedule does not reflect any relative degree of toxic risk of the agents. As we mentioned, 3 species or subspecies of cannabis are recognized as marijuana. Cannabis sativa and indica have relatively high psychoactivity due to the concentrations of delta-9 THC in the buds and leaves of the plant. Hashish is a dried form of structures called trichomes, which are hair-like glands on the leaves and flowers, and which are particularly high in delta-9 THC. Hash oil refers to extractions of cannabis parts by several means and is even higher in delta-9 THC content. With large-scale commercial production of marijuana, cultivars are being produced that contain increasingly high concentrations of delta-9 THC, whereas wild-type cannabis sativa or indica usually contain only a few percent delta-9 THC by dry weight. Cultivars now commonly contain 30% or more delta-9 THC by weight. Much, much more potent than anything seen in earlier decades. You recognize also that the psychoactive effects of delta-9 THC can be modified significantly by many of the other components in the plant. And that is particularly true, we think, of cannabidiol. So at this juncture, we might ask, why do we react so readily to marijuana and its constituent compounds? The answer, in part, is that our bodies, both in the brain and the periphery, we elaborate and use endogenous ligands at cannabinoid receptors that modify neurotransmission and affect immune function, among other actions. The endogenous ligands are believed to be the lipid-derived anandamide and 2-arachidonyl glycerol. There are two G-protein-coupled receptors, CB1 and CB2, which appear to mediate at least the majority of the actions of both plant-derived and synthetic cannabinoids. The CB1 receptor is currently assessed to have the highest expression of any G-protein-coupled receptor in the mammalian brain. The CB2 receptor, in contrast, while it is found in some parts of the brain, it's in much lower concentration than CB1, and the CB2 receptor appears to be expressed to a much greater extent in peripheral tissues. Delta-9 THC itself is only a partial agonist at the CB1 receptor. Stimulation of the receptor mediates the characteristic actions of marijuana as are cited here on the slide. Now, with medical marijuana in the offing, it's important to recognize that while individual sensitivity to the various actions that delta-9 THC can produce may exist, it's safe to say that for the most part, we have non-cannabinoid drugs that are more efficacious at producing those effects and which do not carry the psychoactive liability of delta-9 THC. We've already introduced dronabinol and nabilone as therapeutically available CB1 receptor agonists. Note that they are regulated by the Drug Enforcement Agency in categories 2 or 3. I want to introduce another drug, rimonabant, which is not available because it uniquely acts as an inverse agonist at the CB1 receptor. That inverse agonist action was documented to produce significant weight loss and was very effective in helping individuals stop smoking tobacco. It was briefly brought onto the market. It had some other side effects that caused it to be withdrawn from that market fairly rapidly, but it points out, I think, the therapeutic potential that may still exist in exploration of the cannabinoid receptors and cannabinoid agonists. Those were the major therapeutically significant actions of the cannabinoids, at least of delta-9 THC. So what about the adverse effects of this compound? Well, while many of you may already recognize some of these, it's worth mentioning that adverse effects following ingestion of delta-9 THC containing products can be severe. While marijuana is generally considered as a drug with which to mellow out, excitatory responses like tachycardia and increases in anxiety, which can lead to panic attacks, are not uncommon. And as the concentration of delta 9 THC has increased in the cultivated products that are now available, the incidence of hallucinations, particularly in severe intoxication, has increased. We have been able to identify a unique cannabis withdrawal syndrome that has been identified in people who are frequent or heavy users. It can include irritability, anger, anxiety, insomnia, restlessness, decreased appetite or weight loss, and dysphoria. And we've also recently identified a unique cannabis hyperemesis syndrome, CHS. The CHS is characterized by bouts of prolonged 24 to 48 hour duration of periods of unrelenting nausea and vomiting. It appears to occur usually in adults who engaged in heavy marijuana use as adolescents. And interesting also is the fact that many who suffer from cannabis hyperemesis syndrome self-medicate in an attempt to reduce the severity of the nausea and vomiting by taking very frequent, very hot showers. You should also be familiar with cannabidiol or CBD. CBD is a partial agonist now at the CB2 receptor. It's received approval for the use in severe, otherwise intractable childhood epilepsies. CBD is available as Epidiolex, which is an oral liquid extract. It has a unique Mississippi connection. In 2014, our legislature passed Harper Graves law that approved the use of Epidiolex in the state. Ms. Grace was a child with intractable seizures that responded to CBD, and her parents lobbied the legislature effectively to gain some relief through the legislative approval to use CBD in the state. You'll note that Epidiolex currently has a Schedule 5 designation from the Drug Enforcement Agency. It is still regulated, but at the lowest level of scrutiny in the controlled drug schedule. In contrast to delta 9 THC, which is, as we said, a partial agonist at the CB1 receptor, there is a large and growing number of full agonists at the CB1 receptor. These are all synthetic compounds, designer drugs, if you will. Collectively, they're often referred to as herbal marijuana alternatives. And until relatively recently, as structurally unique designer drugs, synthetic cannabinoids were not regulated by the DEA. However, in 2020, the DEA issued a rule making all synthetically derived tetrahydrocannabinols as Schedule I controlled substances. Prior to that regulation, the compounds were often marketed in products such as K2 or Spice. These substances then were easy to maintain, and they usually appeared as an unknown mixture of herbs which had been sprayed with one or more of the synthetic cannabinoids. So the full pharmacologic profile is often very hard to distinguish. More recently, more synthetic cannabinoids, often designated only by alphanumeric sequences like JWH-018, have been synthesized and are widely available on the drug market. A particularly troubling aspect to this is now more often these herbal marijuana alternatives not only have synthetic cannabinoids, but very frequently are adulterated with opiates like fentanyl or its congeners. The synthetic cannabinoids as full agonists at the CB1 receptor are much more intense than those evoked by delta-9 THC, and they often result in emergency room visits. Typical symptoms of synthetic cannabinoid intoxication are listed here. In the past several years, there's been a high incidence of intoxication seen in the UMMC emergency room. In fact, in younger patients who present with agitation, hypertension, and tachycardia, and if there is any suspicion of use of an herbal preparation, then it's recommended that intoxication by a synthetic cannabinoid be placed high in the differential diagnosis of that patient. As take-home points for this session, what you should be able to do with this material is to differentiate among the agents that act as partial versus full agonists at either CB1 or CB2 receptors. Recognize there are 3 compounds, dronabinol, nabilone, and CBD oil, that are approved by the FDA and indicated for clinical use. In addition, as the legislation evolves, the capacity to prescribe and use medical marijuana will enter the clinical arena. You should also be prepared to recognize the spectrum of symptoms associated with acute intoxication with a synthetic cannabinoid. Thank you for your attention. Please stay tuned to the remaining 2 sessions in this group of lectures. Goodbye.